Hello, this is Kim Burchell. I'm a neurosurgeon at the Oregon Health and Science University, and I want to talk about a tool which we have now developed to help in the diagnosis of facial pain. You may have heard me reference this in other presentations on this channel, but I thought I'd take this opportunity to go into this in a little bit more depth. Before we delve into the tool that we've developed, I wanted to have a brief moment to talk about AI and the forms of AI currently. I'm certainly not an expert on AI, but I think we can roughly divide the forms of what is called AI today into those that are currently implemented and those that may be implemented in the future. Those forms of AI which are currently implemented can be divided into 5 categories. The first is narrow AI, which we encounter in chatbots on virtually every commercial website. Then there are the dedicated reactive machines such as Deep Blue, the chess-playing computer program. Then there is limited memory AI, such as is in use in the self-driving cars like Waymo. Machine learning, as will be exemplified by the tool that we have developed. And lastly, deep learning AI, such as we see with ChatGPT and other large language models. The expansion of AI is clearly where industry is going presently. These advanced forms of AI go by a number of different names, including general AI, more like human intelligence, a superintelligent AI, a theory of mind AI, and even at some point, self-aware AI. I will limit our discussion to machine learning, which is the tool which we have used to develop this application. It is well to keep in mind that AI sometimes gets it wrong. Examples of this include facial recognition, which has developed race and gender biases, hiring algorithms, which have been biased toward males, predictive policing, reinforcing existing bias in neighborhoods, credit scoring, reflecting socioeconomic inequalities, healthcare algorithms which can underestimate health needs of Black patients, and sentiment analysis, misinterpreting sentiments of minority groups. These issues demonstrate that AI is completely dependent on input to develop a model. This is why we spent several years developing the data on facial pain, and in particular on the temporomandibular disorders, to produce as accurate an input as possible to develop the present model. The question then arises as to how many subjects are needed to generate an AI model for health care. The drivers of this issue relate to the complexity of the condition, with more complex conditions requiring more data to capture the nuances of patient outcome, the quality of the data, the type of model that is being developed, the variability in outcomes, and having enough data to generate a statistically significant predictive model. In practice, it's essential to perform validation studies to ensure that the model is generalizable to new cases. Machine learning can be thought of having 2 types of models: supervised machine learning and unsupervised machine learning. We utilized a supervised machine learning approach, employing labeled data sets based on expert opinion. Examples of this employ classification and regression models, which we will discuss in more detail. Classification models employ supervised machine learning that builds models that are able to distinguish 2 or more discrete classes, such as cancer versus no cancer. Logistic regression is a classification method that uses a logistic function for predicting a dichotomous dependent variable. For our models, we chose both approaches since each has its own advantages. And as you will see, we later compared the predictive capacity of both approaches and found them roughly equivalent. As far as classification modeling, we used 2 different analytical approaches, those being random forest, using a number of randomly generated decision trees for ensemble learning by using a bootstrapping technique, and a support vector machine approach which classifies data by defining a boundary, what's called a hyperplane, that best differentiates two groups. Those two models, combined with a logistic regression approach, represents how our data was analyzed and modeled. Categorical data lends itself to logistic regression analysis. Random forest bootstraps multiple decision trees to determine the most accurate model. The support vector machine classifies a hyperplane boundary that best differentiates two groups and performs well with small data sets. Both random forest and support vector machine approaches have a generally high degree of accuracy. Both can be subject to the risk of overfitting, a term which we will define shortly. And so, to summarize, we pursued a supervised learning approach and a classification scheme using random forest, support vector machine, and logistic regression analyses. AI models are subject to both bias and variance. This is where the terms underfitting and overfitting come into play. When the data do not fit the desired relationship, such as this attempt to fit the data to a linear regression curve, the model is guilty of so-called underfitting. On the other hand, if the data is overfitted to a particular relationship, as shown here, the model may not be generalizable. Obviously, the best models are dependent upon the accuracy and consistency of the data to avoid the errors of under and overfitting. The receiver operating characteristic curve, a method that was first developed during World War II for radar operators, compares the true positive rate and false positive rate of prediction models and has come to represent an important indication of the accuracy of models developed by machine learning. The ideal ROC curve would have a 100% true positive rate and 0% false positive rate, as shown in this diagram. The problem of facial pain is that it is a challenging diagnosis for both patients and clinicians. Accurate diagnosis is essential for effective treatment. Many clinicians, including neurosurgeons, neurologists, and primary care physicians, treat trigeminal neuralgia. This disorder has a specific history and also responds to medical therapy. A much more common group of problems, called the temporomandibular disorders, can easily be confused with trigeminal neuralgia. The reason is that trigeminal neuralgia and the temporomandibular disorders share a common set of clinical and historical features. In both, pain radiates into the trigeminal nerve distribution. The pains can also be episodic in character. In both conditions, pain can be aggravated by chewing and talking. And finally, the pain may be relieved by anticonvulsants, but in the case of temporomandibular disorder, the pain relief is usually modest. The correct diagnosis of facial pain is in fact paramount. As mentioned, the temporomandibular disorders can be easily confused with trigeminal neuralgia. The real problem is that the TMDs are at least 1,000 times more likely to appear in clinical practice than the disorder we call trigeminal neuralgia. The diagnosis of trigeminal neuralgia can usually be made by either listening to the patient by phone or even by telemedicine. However, a TMD diagnosis requires an in-person encounter with a physical examination. Furthermore, TMD needs to be strongly considered in cases of atypical trigeminal neuralgia, or what I have previously called trigeminal neuralgia type 2. Roughly 10 to 15% of the population does deal with some form of a temporomandibular disorder. This places it as the second most common myofascial pain syndrome in humans, second only to low back pain. The big problem is that almost no providers are trained to either diagnose or treat TMD. Dentists typically don't have much to offer TMD patients, since the TMDs are generally treated with physical therapy, although dental correction or further surgery is rarely indicated. In contrast, trigeminal neuralgia often responds initially to anticonvulsant medication. In patients that are intolerant of medication or who eventually fail medical management, surgical management of trigeminal neuralgia can usually resolve the pain rapidly. For further information on the diagnosis of facial pain, I would strongly advise that you review the video on this channel with regards to the diagnosis of facial pain and trigeminal neuralgia. Given the commonality of the temporomandibular disorders and the potential for confusion with the diagnosis of trigeminal neuralgia, we wish to begin the development of an online tool for clinicians that evaluate and treat patients with facial pain. Our hope was that this tool could assist in the diagnosis of facial pain, as well as to point patients toward the appropriate medical and surgical management of their pain. This work was published in the journal Neurosurgery last year in 2025. The data to develop our machine learning models was derived from a questionnaire of 47 questions and 5 findings from their orofacial examination. 101 patients were classified as either having a temporomandibular disorder or a trigeminal neuralgia diagnosis. This was based on the completed questionnaire and an orofacial examination by a neurosurgeon and a TMD specialist. Patients with more categorical facial pain diagnoses, such as trigeminal neuropathic pain related to inadvertent injury to the trigeminal system, trigeminal deafferentation pain related to intentional injury to the trigeminal nerve or its system, symptomatic trigeminal neuralgia related to multiple sclerosis, postherpetic neuralgia related to a prior history of herpes simplex on the face, and glossopharyngeal neuralgia were not included in this analysis given the specificity of their diagnoses. As described earlier, we used 3 different methods to create machine learning models using the random forest classifier, logistic regression, and support vector machine analyses. The results of the 3 models used were remarkably similar. The random forest model was superior, but only slightly, at 92% accuracy, whereas both the logistic regression and the support vector machine came in at about 89% accurate. In comparison to an ideal ROC curve, our data was quite respectable for all 3 methods, including random forest, logistic regression, and the support vector machine, as shown here. The most important aspects of the physical examination and questionnaire proved to be tenderness to lateral and interarticular palpation of the TMJ on physical examination, and the question of whether your pain is entirely or mostly brief, that is seconds to minutes, and unpredictable sensations of electrical, shocking, stabbing, or shooting. The former physical finding pointed towards the diagnosis of TMD, whereas the questionnaire finding of brief pains pointed more towards trigeminal neuralgia. While this physical finding and the historical feature on questionnaire were important, we found that using all of the questions and findings was more specific than any single question or finding on physical examination. The limitations of this study are something to consider, but we do believe that this is a good first step toward understanding the condition of temporomandibular disorder and also how it relates to trigeminal neuralgia. Any study like this must be subject to external validation of independent data sets to ensure the generalizability of the model that we have developed. Even if validated, use of this and other AI models must be balanced with clinical expertise to avoid over-reliance on algorithmic outputs. Based on this and other studies, we believe that smaller samples can still make important findings if criteria for inclusion are rigorous and based on expert opinion. The analysis of this network model indicated that TMDs and TN can be reliably differentiated using a standardized questionnaire and physical examination with approximately 90% accuracy. These tools may provide useful information for clinicians interested in this distinction. I'd like to thank you for listening to this presentation and wish you all the best in your analysis and treatment of patients with facial pain.